And here we go, as promised, the criteria for a substance use disorder. This will cover 2 slides. Taking the substance in larger amounts for longer than you meant to, wanting to cut down or stop using a substance but not managing to do so, spending a lot of time getting, using, or recovering from use of substance, cravings and urgings to use the substance, not managing to do what you should at work, home, or school because of substance use, continuing to use even when it causes problems in relationships, giving up important social, occupational, or recreational activities because of substance use, using substances again and again, even when it puts you in danger, continuing to use even when you know you have a physical or physiologic problem that could have been caused or made worse by a substance, needing more of the substance to get the effect you want, so the development of tolerance, development of withdrawal symptoms, which can be relieved by taking more of the substance. So you can see that the 2 prior assessment tools, the DAST, really helps you gauge how many of these criteria that youth is fulfilling. So again, these really, for a youth less than 14, if they score more than 5 on the craft, that really is highly suggestive that that child has a severe substance use disorder, or what we would say is signs of addiction. The preferred language now is severe substance use disorder. And this would be an occasion to break confidentiality and tell the youth that they really are in danger and that they have a really grave problem, and that we need to invite your parents in and make a plan together for their own safety. So in a youth that admits to some substance use, you've done an assessment and you don't feel that the parents need to be invited in, but you want to have a discussion about their use. This is a time to do a brief negotiated intervention, or using some motivational interviewing techniques, make a plan to see if you can negotiate some change. So the brief intervention focuses on increasing insight and awareness regarding substance use, and draw on intrinsic motivation, get that dopamine surge ready to go to drive change. Most teenagers, though, do not realize they have a problem. So first of all, you may need to do a little bit of education around what is the average substance use for most of the adolescent population, and then sort of see if they can't find some insight into how their own use might be affecting what's going on in their world. So brief intervention can be used as a standalone treatment for those at risk, as well as a vehicle for engaging some who need more intensive levels of care. It doesn't need to be long. It can just be a few minutes. And motivational interviewing is a really powerful way to do this. It takes practice. It's helpful to take a course. So this online module hopefully will motivate you to take a motivational interviewing course. The basis of motivational interviewing is collaboration with the patient. It's very much patient-centered, and it really is there to elicit their own strength and their own desires to change. It respects their autonomy, it fosters patient resilience, and it evokes their own reasons to change. Motivation is a state, it's not a trait. Ambivalence to change is normal, and it may take several visits with a youngster, so follow-up, and that's why this is great to do in primary care. Follow-up is key, because a lot of times people aren't sure they want to change. So a good motivational guide will sort of ask where they want to go. They will listen and respect what the person wants to say and wants to do. And this is true with adolescents, and you're going to get more buy-in if you respect what they have to say. And it informs people about choices to achieve their goal and allows them to make choices that make sense to them. So a lot of people will use a frames guide when doing motivational interviewing and brief intervention. So feedback is given to the individual about personal risk. Responsibility for change is placed on the individual participating. So on the adolescent, I find that sort of a little bit of a relief. You can advise change. You can offer a menu. Empathy is key here, but the patient is empowered to make their own change. So you need to have rapport with the patient. You need to ask them permission if you can give them information, and you really want to explore what they're doing. Sometimes it's very helpful for adolescents to, particularly if they have no insight that they have a problem, to outline the pros and cons of their current use patterns. You may want to use a skill called reflective listening. So let the child or the adolescent talk and then say what you've heard back to them or summarize back to them so that they know that they've been heard. During an interview, you can provide feedback, and this is critical. Sometimes it's helpful when you're working with an adolescent to just say, hey, what do you know about marijuana? And if they really give you a blank look or they say they don't really know anything, ask permission if you can give them some information, and don't give them the Encyclopedia Britannica version of information. Give them one or two facts and then see what they think about it. Motivational interviewing and interventions can be done well and they can be done poorly. This is from Boston University, and they have a great website on motivational interviewing.